And I will introduce our speaker, and then we will have question and answers at the end. I'm conscious we're a little bit late starting. I will keep an eye on questions in the chat. I will keep an eye on you putting hand up, but we will cover questions at the end. So hopefully that's okay. So without further ado, let me introduce our speaker. We are really, really lucky to have him. He's a professor of health services in the Faculty of Health and NIHR Applied Research Collaboration, ARC, in Southwest Peninsula University of Plymouth. That was a very long sentence I read off. He's an expert in social prescribing. He leads a research program around evidencing and developing non-NHS delivered interventions. He's managed various social prescribing projects in the UK and internationally on implementations, rollout, scaling, impact, and roles for social prescribing. These have been funded by UKRI, NIHR, EU Horizon, and others. And he's also led the creation of the Academic Collaborative for the National Academy for Social Prescribing and has conducted extensive policy-focused work for government departments, including the DHSC and the Department of the Environment, Food and Rural Affairs. So after that slightly garbled introduction, I will hand you over to your speaker. Hopefully you can share your slides.
Thanks, Angela. That's great. He is also very bunged up because his children have brought illness home from their primary school. So I apologise for that. Can you see slides and hear me and stuff all right?
I can. Brilliant. Thank you.
Perfect. Yeah, thank you very much for having me as part of this series. So I've known Holly a while, and these are great things to do, and I'm really pleased that there was some interest in social prescribing, that people want to come and hear about it. For me, it's a really nice example of where health services research, health service delivery, evidence and policy meet, and it can teach us a lot about the way in which things get rolled out, how we evidence them, what happens, especially in the health promotion and prevention space, where perhaps capturing outcomes is a little bit more tricky. So I think it's a really nice example. As you just said, I'm Karen. I'm at the University of Plymouth. We're part of an applied research collaboration, which is an NIHR infrastructure organisation. We cover Exeter and Plymouth. So what I wanted to do today was to give a bit of introduction and background to where social prescribing comes from, what it looks like, and how it's been implemented in England. I mean, that may not be new to a lot of you, but I think it frames how we produce evidence, what happens to that evidence, and then how we end up telling the story later down the line of social prescribing. I want to outline a little bit about the services that are involved in social prescribing, how it's funded, if it's funded, how it's delivered. I want to say a little bit about evidence, what it's like to produce evidence in a space where things are often quite politically driven, and how that evidence gets taken up if it does. I want to say a little bit about where I think social prescribing is at the moment, and I've called that splintering, and I think there are some good examples of where social prescribing is breaking off now. I want to take some guesses about what's going to happen in the future. They'll obviously be totally wrong, but it's what we look like from here. And then I want to just outline a little bit of the work that we've done here in the Southwest and across England, in case anybody's interested to go and have a look. So this is a bit of a cliche, isn't it, this slide? But I really think this is what social prescribing, I think this encapsulates social prescribing. So lots of people on the outside of the English and the UK case would look at social prescribing here and say, well, it looks great. Frankly, we're a front runner. We've taken a big investment. Social prescribing has been national policy, and things look great, and we're often held up as an exemplar globally as and there are good reasons why we should, but actually it's messy. There's loads of people involved, everybody's got their vested interest, it's not been rolled out smoothly, people are pushing different agendas, and so it's that Instagram versus reality thing. And I want to tell that story a little bit here, social prescribing, what it looks like on the shiny outside, and then actually how it functions and how it's been rolled out and what the differences might be. So social prescribing has a long history, and I would be surprised if I'm telling anyone anything new here, but social prescribing has existed for as long as family doctoring and general practice has been in practice, and in fact before that. Local communities have always interacted with general practice and the medical system, and community approaches to health again have a really long history. And so it's no surprise that they come together in a particular way, and something that looks like social prescribing then starts to emerge. And I guess we could start to think about that in the late 80s and early 90s with things like time banks in South London or exercise referral schemes in the 90s across England. And these things coalesce around ideas of linking general practice, primary care, family medicine to those community approaches to health. I really think that there is a social movement around social prescribing. So there were some real front runners, and there are people like Marie Polly, Mike Dixon, Sam Everington, lots of people that I'm sure are familiar to you. And those people really pushed for something that looks like social prescribing to be embedded in England. It's really important to know that that was a lobbying movement, and they got a huge amount done in a short period of time. And it's a really interesting story about how to get things into practice. So we've written some of that up. It's referenced there. Go and have a look if you're interested. And because of that social movement, because of those early sort of front runners, if you like, the policy starts to shift. And there was already this receptive policy context around the personalised care agenda, around people trying to adapt primary care to do something that was more person focused, that was more strength based, that was more what matters to you rather than what's the matter with you, which is the classic phrase. In 2018, there were some pilots that put some money to those good ideas. So all this stuff starts to coalesce around how are we going to do it at scale. It takes cash. So in 2018, there were these pilots through the Health and Wellbeing Fund, and they funded link workers. Now, the idea was that as link workers rolled out, as there were more and more link workers across England, the funding would shift. So at the beginning, it was 100% Department of Health funded. And then the idea was that over a 4-year period, it would shift to being 75% public health funded, so that this was going to shift into being early intervention, health promotion, public health. That never happened. And I think that tells us quite a lot about the way in which social prescribing has been rolled out, what success looks like. And it also says quite a lot about public health agendas and what we value and how we roll things out. What actually happened was that in 2019, that link worker role was written into the long-term plan for the NHS England. I'll say more about that in a minute, but that basically took that role between primary care, community, and scaled it across England. So this is some writing from NHS England just as it was going into the long-term plan. And this tells us what it was that NHS England valued about social prescribing at that time. And I think it's important, and I've highlighted the bits that I think are critical in red here, that NHS England was saying that there is more to health about the absence of disease. It's about social, emotional, and physical well-being. That talked to that personalised care agenda. It talked to the shifts in policy. But social prescribing was trying to address three things. We wanted to reduce the pressure on the NHS, and that was at the top for a reason. That was critical. It was designed to improve people's health and well-being outcomes and to strengthen community resilience. And actually, these were the 3 domains of the NHS outcomes framework that went alongside the long-term plan. So I think this is useful, although it's a bit of a historic document now. This is genuinely what success looked like for NHS England at the time. It tells us a little bit about how social prescribing was then measured. What were the metrics by which people thought it would work? Right, so to come a step back, what actually is social prescribing? And again, I don't think this will really be news to anybody on the call, but I've showed this diagram quite a lot to various different people, and especially people in policy, because social prescribing, I think, is an idea. I don't think it's a complex intervention as a standalone. I don't think it's a single coherent entity that you can then pick up and put somewhere else. And then because it's an idea, it's been interpreted in different ways, and it's been implemented in very different ways. And we've written some of that up, and there's a citation there. Because of all of that, it's important then when we have conversations about social prescribing to start with, what is it we're talking about? And for me, it's this really basic model, and it is a bit noddy. I know it's like crayons and paper and stuff, but I think it's important. So for me, something is social prescribing if you have these 4 components and the links between them. The first one is that there must be an individual. There must be somebody who needs something, and it's a bit basic, but that's the starting point. There's then got to be a referring organisation, and that's often primary care, it's often GP, but can frankly be anything. So if that individual is going to a referring organisation to do something and the intention is there, that's our first half of the social prescribing model. The second half is that there has to be a link worker role. That's often a person. In fact, it's often the person that the NHS have funded in England, but it could equally be someone somewhere else performing that role. It could be someone just works in a local space, and that breadth is really important. But there has to be that linking function. And then at the end, there has to be some sort of activity that happens outside of standard care, outside of the NHS. And we can say a little bit more about that in a minute. But if those 4 boxes are there, the links between them are there, I would say that looks like social prescribing. There is a huge amount of blur, of complexity, of difference in the way that that's been implemented. But if those ideas are there, I would say that was social prescribing. That has huge implications for what social prescribing looks like in practice, but also how we generate evidence around social prescribing. It's not necessarily sensible to say, does social prescribing work? It's more sensible to say, which bits of it function, for who, in what ways, and where can we put evidence to demonstrate that those links or components are functioning in particular ways. So taking a realist approach, for example, would make a lot more sense for big social prescribing programs than some of the blocks in themselves. We could do trials of activities, you could do really good deep qualitative work of the referrer-patient interaction, and then you piece it together. So this has big implications for what evidence and policy rollout look like, I think. So if we take that classic pathway, that basic diagram, a classic social prescribing pathway would look like someone going to their GP, reporting maybe symptoms of mild to moderate depression, and then seeing a link worker who would talk to them for 45 minutes about the way in which their life was operating, the things that worried them, the things that they were concerned about, the things that they liked, the things that they were considered to be good at. And then that link worker would help that person find things in the local community for them to do. And that might be arts-based stuff, physical activity stuff, finance or debt advice, or it could be something in the natural environment. I'll say a lot more about the green stuff later. Those activities themselves are often time limited, so people often do a 12-week program. There isn't a huge amount of evidence for why it's a 12-week program, other than that's what people can get funded, and it's just sort of become entrenched in the literature. I don't think there's a huge amount of mechanistic rationality to that. And then people tend to, if they've engaged with that 12-week program, they often try to stay engaged. So there's often ongoing volunteering or leadership, and those feedback loops we know are really good for people, especially in terms of health promotion. Those activities tend to be symptom or need led. So there'll be diabetes walking groups, there will be various different swimming groups, and they are sort of self-selected groups of people that get together to do something. So that's that classic program. And that's what was funded. That's what was considered a good idea in policy. But of course, that's not really what happens in everyday life. So we know, for example, that as social prescribing started to get a lot of traction here in the UK, link workers found themselves doing a lot of crisis management and making sure that people had somewhere safe to be, had enough food to eat, could access things that were really basic needs. The need in the community was so great that link workers were doing a huge amount of firefighting. And I mean, we know that to be true of all areas of the health service, but social prescribing became this pressure release valve for a primary care that was really struggling. Who is it that's actually delivering this social prescribing? Well, it's a coming together of lots of different organisations in the health service, but also more broadly. So again, in that classic pathway, that sort of 2019-2020 funded programme, it was primary care networks, integrated care systems, neighbourhood teams, and then the VCSE and other activities, often small organisations coming together to deliver these pathways, these social prescribing pathways, so that somebody could transit across each of those components. And that meant that delivery is based on relationships, and those relationships are formalised through contracting, and often lots of ad hoc arrangements are put together to enable those pathways to function. So there's a lot to go right, but there's a lot to go wrong. As I said, local public health teams had a role to play here. The intention was that it was going to be a large role and there was going to be quite a lot of money to go with it. When that money never materialised, or when the policy shifts happened, it became a little bit unclear about how public health teams should be involved in these social prescribing programs as they got up and running. And therefore, the focus around prevention and public health was diluted slightly, I think. And so social prescribing's benefit to those two things became a little bit reduced because it was concentrating on the more primary care medical stuff. I'm not making a value judgment there. That's just what happened. All of that stuff is organized around that link worker. That link worker was the person that was funded. It was the role that was central to all of this stuff. So social prescribing in the early days or systematized days here was the link worker. And that was complicated because there were various different funding routes. So link workers could take money from the voluntary sector, from NHSE, from the additional roles reimbursement scheme through primary care. Initially, there was some scale and salary differential, and that created some problems. But also then obvious problems around where we site link workers, who has access to what training, what skills do they have, where they sit, what they've got access to. So we know that immediately became quite a high pressure role, and people interacted not maybe with their local link worker, but with Steve, who's been here for 5 years. And that put a lot of pressure on link workers, and Steph Tierney at Oxford's done some great work looking at what that pressure then translated at. What was the mission creep? What was the role differential? So it's all organised around the link worker. Importantly, again, especially in the early days, all of those people in that system, and especially the link worker, had to navigate all of that complexity without a huge amount of guidance or help, and they were doing it in a way that was quite time pressured. So people were generating relationships based on previous relationships and trying to make things work. And I guess, again, we've seen this in health services time and again, people are just getting on with really good work, and then eventually it formalizes and it crystallizes around them. So money, I've mentioned that a few times, and I think money is always the thing that there are always many questions around funding for social prescribing. All of those components that I've just talked about need cash, they need resourcing, they need time, and they need money, and they need people to do it. So this was and is the sticking point around social prescribing. So there is currently, and there was, funding for link workers. The large investment was through the R scheme in primary care networks. But there has also been lots of different ways people have been funded through the VCSE and various different grants. The other critical bit is activities, the community things that people end up doing. That's not really been properly funded through central mechanisms to date. And those community organisations are doing what they've always done, which is small grant capture, really time sensitive, urgent small grant capture to allow them to continue to function. Social prescribing has given them some leverage, and it's given them some opportunities that they may not have had before, but it's also increased the competition and potentially prioritised bigger organisations. So social prescribing has entered into this voluntary sector mix of grant capture and created havoc in good ways and bad ways. It also creates a power differential, and Chris Dayson at Sheffield has written a lot on the ways in which social prescribing has impacted the voluntary sector, and there's a lot to say in there. There are some new routes for social prescribing to be funded, and the sort of grand idea, and it is a very good one, from the National Academy of Social Prescribing, is that there should be shared investment funds. So this is match funding from national to sort of regional, local, where people pay into a shared investment fund, and then that can be distributed around organisations and different roles delivering social prescribing. It has a lot of traction, it's got a lot of policy traction, it has a bit of money, and I would be quite optimistic about it getting going, but it's not currently operational, it doesn't currently work. So there has been also some interest from other government departments and UK Treasury. So the initial routes were through Department of Health, NHS England, but also other government departments like DEFRA have, quite rightly said, well, green social prescribing talks to a lot of the things that we're interested in. So what is it that we can do? And there have been bids from DEFRA into UK Treasury to try to roll out green social prescribing, for example. So bits of government, bits of Treasury, bits of national infrastructure are making good inroads in how social prescribing is funded. All of that is in of course, a context where health service funding itself is shifting fairly fundamentally. So we've moved from CCGs to ICS to neighbourhood health, and whatever comes next. So everybody is playing catch up with where the money comes from, how it gets spent, and how it can be best used. So that talks for me anyway, quite a lot about the dual arrangements of social prescribing. So those boxes I talked about, the people doing it, the money, it's often more developed at the local level. Social prescribing functions often really well at the local and hyper local level. Those ad hoc relationships are built on people who've worked together for a very long time and know how those organizations function. So it often just works. And in GP surgeries or in practices, there are often champions for social prescribing who make that work. They push that forward, they put it on the agenda, they have some resource and time to put to it. Link workers themselves, finding themselves in a very pressured environment, they coalesced around one another and formed groups. They self-organized ways in which they could work together. They framed, WhatsApp groups and platforms, and they really came together. And there was a good, well, from the outside anyway, it looked like good communities of link workers pushing things forwards. That linked with really good community development work. So, of course, the whole of social prescribing is premised on the fact that we need investment in good community development work, communities doing things of and by and for themselves, as Cormac Russell would quite rightly say. And link workers, certainly at the outset, had time to do some of that community building and to have time to go out and understand what was happening in terms of those activities in their local areas. So those ad hoc relationships were strengthened by people going out and having coffee and lunch and working out what was happening. So you have these emergent boundary spanning networks where people come together around social prescribing where they may not have done before. And I think that was really beneficial and continues to be. At the national level, social prescribing was a bit less joined up and probably continues to be, actually. So NHS England was driving a lot. In fact, there was an online platform, there was a lot of policy, there was a lot of training, and all of that was incredibly useful. And it was really good to see NHS England taking such a role in bringing people together around social prescribing. And it was a real positive thing, especially in the early days. And that money then went into funding things like the National Academy for Social Prescribing. So I'll say a bit more about them in a minute and come on to them. And again, those government departments like DEFRA are really taking a lead. But more importantly, those self-emergent networks became national. So the social prescribing network pops up, and that's got a lot of traction, quite rightly. And there's other emergent networks around populations. So we see the social prescribing youth network. We see lots of different areas where people have come together. So it is often little networks aggregating up and then linking with the national policy that was coming out. I think that's how social prescribing has played. So this is sort of a warning slide, I guess, in that all of this lands in a space that was very high pressured. And I go back to Kate Mulligan's term. She's a brilliant academic and policy leader in Canada who's done a lot around social prescribing. But she makes the point repeatedly that social prescribing isn't new, but it's newly systematized. And we would do well to remember that, because there were lots of people in this space before that system recognized it, before that money recognized it. And so all of that good community development work that was happening and all the people who know how to do community health really well were then swept up, sometimes swept aside, sometimes swept with this new systematized version of social prescribing. And lots of people were very critical of that. And I have a lot of time for those arguments. So people like Cormac Russell have said that social prescribing often does exactly the wrong thing. It focuses on individuals. It's very medicalized in its approach. It's quite a neoliberal version of health that doesn't recognize structural and systemic pressures towards ill health. So it's a warning to say that social prescribing isn't universally loved. It's certainly not a panacea, and it can often paper over the cracks of a system that isn't doing the right thing. Because it came with money, people often then gamed the system, quite rightly. If you're a small voluntary sector organization and you see an opportunity, of course, you're going to try and either rebrand or rejig or do things in a slightly different way so you can leverage into this new way of working, often for really good reasons, sometimes for less good reasons. So there are social prescribing cuckoos, things that maybe look like social prescribing but aren't, or things that aren't that do look. And all of that is in a context of these broader non-NHS delivered interventions. So social prescribing is only one of quite a few things that look quite similar. So I think what I wanted to do was say what it is, where it comes from, where it sits, who delivers it. And that's sort of what we talked about for the last few slides. And because that public health funding dropped off, it often isn't the case that prevention is high up on the agenda for social prescribing, although it blooming well should be, because social prescribing could be really good at this. So I'm sort of pushing my own work a little bit here and saying that we think as a group that we as a community should think about social prescribing in a prevention way, and we should think about how we design, implement, and evaluate social prescribing in a way that captures the things we all know about prevention. So we can run all the way through universal prevention, selected, indicated, through to health promotion. If we think about social prescribing that way, it would help us better define the population, how we can approach that population best, and how we can then match existing programs to the people that might need it before they pitch up at primary care. So we think this is a way that we should try and shift our thinking on social prescribing to be more left than we are now. And we can talk about that more in a minute, but I'm just pitching our own framework that we got there. So I want to move on now to talk a little bit about evidence in this space. So what does evidence look like? How has that story been told, and where are we now, I guess? So I said a little bit about the National Academy for Social Prescribing. This is an organisation that appeared, if you like, in 2019. It was the Department for Health and Social Care investment in 2019, quite a large investment. Matt Hancock was the person that really pushed that forwards. And it was to be positioned, it was an organisation to be positioned between the health sector and the voluntary sector, not wholly in either of those spaces, to champion social prescribing, to be an organisation where people could coalesce around what social prescribing is, so they could support, connect, champion, catalyse, shout. This is their words, not mine. And they did exactly that, actually. They were a good space, are a good space for all things social prescribing. They are very positively framed and they push the space forwards, but that is their role and they do it well. They also, at that stage, had an evidence role, because that early story around policy and pushing things forward and the social movement was done in a space where there was not high quality, robust evidence. This was done for reasons where, firstly, this feels like a good idea. It matches what things we know work, but it wasn't an implementation study followed by, or sorry, an effectiveness study followed by an implementation study followed by scaling and rollout. It's the other way around. So NASP realized it had a role to play in generating evidence, and here's some of the things they were interested in, and we were part of that story down here in the Southwest. So in the very early days of the National Academy, we felt that there should be an evidence collaborative, and they agreed and they put some money to it. So me and 7 other universities, quite possibly some people on the call, got together and said, let's do this together. So instead of academic funding, which often forces you to compete, let's come in together and we will try to form this collaborative where we can do social prescribing research under the banner of National Academy for Social Prescribing and build that sort of head of steam, I guess, around research and practice and put it all in one place. And it's quite a grand name. We did a little bit of it, but we wanted to do the right thing, basically. So we set out to create a library of useful evidence and identify what the evidence needs were in this space. Because if you've already rolled something out and you've already sort of done this at national scale, what is it that people want to know? So we had this evidence collaborative, we came together and we conducted quite a large prioritization exercise in 2021, to see of all those stakeholders around social prescribing, what is it that people want to know? What about this story is it that people haven't captured? And I'm still talking about this now because I think this tells us a lot about what was going well and not so well in social prescribing, and I think that's probably still true now. So these were the 6 things that people wanted to know. How much does this impact on the economy? How can we fund it in a way that's fair and equitable? How do we know it works past the short term, the very short term? On what metrics do we think it works past the very short term? Who is it that's not using or is using social prescribing, and what's the breakdown? And are we leaving people behind that we often leave behind in health service? So, I mean, they're pretty basic questions, but we didn't know this stuff really very well as social prescribing was being scaled. So what has happened is, in light of a lot of that evidence, in light of the political traction, and in light of financial investment, social prescribing has become universal in the UK. Well, in the UK. So there are now more than 3,500 link workers at the end of 2023. Daisy Fancourt's done some great work crunching the numbers, and there's some, loads of papers of hers you should go and read. But there were, for example, there have been more than 9.4 million consultations that have involved a social prescribing code, and 5.5 million of those have specifically led to a social prescribing referral. There's a team in Manchester led by Paul Wilson who've done some great work looking at the impact of that scheme, the NHS scheme of link workers. And you see what you would probably expect is that you would see small improvements in patient experience. People really engage with it. And for those people that engage and for those people that have been approached, you see slightly better outcomes. And that's probably what you would expect from something like social prescribing. There are huge amounts of devils in the detail there, of course. So when you think about the economic impact or when people engage, we may raise service use in the short term. It may decrease things in the longer term. Where do you see health impact and how do you see it? So you see what you would expect, but it's really useful to get to the detail, I think. So this is where we are now. This is and this is Nick Gitcham from NHS England's slide, but just when they're shared, this is a nice summary of where social prescribing has got to. So where it started, what policy changes have happened, and where we are now, where this sits in current policy. I think it's really interesting for us to think about then how we then adapt and tailor social prescribing to do prevention and health promotion, given where it sits now. So what's currently happening, I think, is splintering. So social prescribing is that classic pathway where everybody came through primary care and went out and did nice community activities. Still happens, but actually it's more important now for programs and the way the health service is set up to approach people who really need social prescribing. So we know, for example, that there has been a huge increase in the number of entry points that people can take. It's not just primary care, but it's community groups, schools, colleges, whatever it might look like. There's huge diffusiveness in the way people engage with that pathway that I showed. So we know, for example, that people don't always stay for the 12-week session. They come and they do various other bits, or they may self-refer to the link worker. They may come in for different bits. So that classic model has started to shift and change. And there's a lot more focus on who's doing it and what exactly they're doing. And that's exactly right, I think. So I wanted to give a couple of examples of where this splintering has been really important. And one of the things I'm really interested in is how social prescribing might be useful for children and young people's mental health. And we know from loads of work around children and young people that firstly, they experience mental health difficulties in different ways. They present in different ways. How they see solutions is done in very different ways. And therefore, social prescribing has to function in a very different way. You can't have that classic pathway through primary care. That isn't appropriate. Well, it's not the most appropriate. It is appropriate, not the most appropriate. What children do at the far end is also going to be very different. People are not going to be necessarily going on a nice walking group in the Eden Project, but they may want to do, well, anything that young people want to do, and that looks very different. What looks like success for young people is then, of course, much, much different. And it, of course, now talks a bit more to prevention, health promotion, public health. And you may indeed even need specialised link workers and different access points. So we've tried to capture some of this by saying social prescribing looks very different and is splintering and is becoming different for children. And we've got a research program called Choices. And we made a few arguments and tried to do a bit of research around this, where we said that social prescribing was universal in principle, not in practice. Young people under 17, weren't using adult services. What we knew about social prescribing was about those adult services and the adult entry points, and young people weren't using them. All of the policy I've talked about was around adults, frankly, and the children and young people's mental health policy wasn't linking with social prescribing policy. So for us, our research program said, where do we put children and young people's social prescribing for it to be most important, for it to be most used, most useful? So our first Choices project did two things. We said, what does that pathway, my silly diagram, look like for children and young people experiencing mental health difficulties? And we spoke to young people, we spoke to various different stakeholders, spoke to lots of people about how that might work. And then we wanted to understand what the community activities look like for children. And of course, all of that was very different. Go and read the papers, hopefully you will. And we're now taking that forward by saying, well, actually, this also has a role to play in more formalized children's healthcare services. So we're currently doing some program development work looking at how social prescribing might work for children on a type 1 diabetes pathway in secondary care. It has a role to play, but it looks very different from all the social prescribing that we've talked about in the past. So that's one of the splintering areas. Another splintering area is around different populations. And there's a large trial currently happening across Europe, EU, Horizon funded, which is saying, does social prescribing look like something that would enable us to engage populations often left behind in European health services? So we're very interested in whether we can engage people from the LGBTIQ plus community, older people experiencing loneliness, and refugees and migrants. They're communities that often experience health services not in a way like other people. And so can social prescribing help us do better? This is being run out of Berlin. It's a 5-year trial, process evaluation, qualitative study. Again, I'd encourage you to go have a look at the link because it's a great project. But again, it shows social prescribing is needing to be tailored and adapted to do the right thing for people who really need it. So that's the cohort end. Social prescribing is also adapting at the activity end. So all the different things that people end up doing. And now talk about there being 5 pillars of social prescribing. So arts and culture, heritage, green, all that stuff. We're really interested in the natural environment end of social prescribing. So my colleagues at the European Centre for Environment and Human Health at the University of Exeter have done a lot of work looking at the mechanisms by which going out in the natural environment can be a really good therapeutic prevention and early intervention activity. This diagram, which I really like, is those 9 mechanisms by which we might think people may get benefit from something like green social prescribing. So people have done that really good science to say, what do those activities do for people? And then alongside that, there's been a huge scaling of green social prescribing in the UK, thanks largely to an investment through DEFRA and UK Treasury that I talked about earlier, who invested £6 million in 7 sites to just do green social prescribing, scale it at a system level, make this work. That was rolled out. There was a very large evaluation that went alongside it. And again, we found things that you would probably expect. 8,500 participants. There were improvements in well-being that you would see. It did reach those groups that are often left behind. So we saw where interventions, green interventions were targeted. It reached refugees and migrants, global majority. It got to those people that we often leave. We found that it was cost efficient when it was compared to standard therapy, CBT, whatever the other stuff was that people would get. And there was a positive return on investment, but there's a longer conversation to have about SROIs and whether we think that's appropriate. But the real learning for us was about how you embed something like green social prescribing into complex systems. And again, I would encourage you, if you can, to go and read those papers. I think they're great, but you may not. So where do I think all of this is going? So hopefully we've told the story of where social prescribing came from, what it looks like, where it's probably splintering a little bit. So what do I think is going to happen next? Social prescribing is business as usual. It is well embedded as part of primary care teams. It will continue to be so. It is, at the moment, implemented across the system. It covers voluntary sector, health and statutory. Link workers are still the linchpin, but it exists. Again, those targeted and focused programs are reaching those in need. So it's clearly doing some good. However, what I would say is I think there's probably waning in the policy enthusiasm and traction around social prescribing because it's business as usual, because there are bigger problems, because there's lots of acute things happening in the health system at the moment. Social prescribing is shifting and it is starting to drop down the agenda ever so slightly, I think, and understandably so. There are also new roles that look a little bit like social prescribing that are getting up and running. So there's CHWIs, community health and wellbeing workers. These are more place-based. They have a responsibility for a number of households, but they're also more prevention focused and health promotion focused. So these are individuals going out into local areas and encouraging vaccine uptake, doing blood monitoring or various other things, as well as stuff that looks like social prescribing. So how can we, as evidence nerds, I guess, or people interested in developing the health service in an evidence-informed way, navigate these shifts and try to place all of those roles in a way that makes most sense? And that's currently where I think we're looking in terms of social prescribing. How do we navigate all of this shift to make sure we're doing the best thing for all those people that might need it? What have we learned along the way that will help us do that? Well, for me, there's a few bullet points, and they may sound quite obvious, but for me, they're the important things. So we won't all agree a model. Social prescribing isn't a single thing. And if we try to all agree that social prescribing is this coherent entity, I think we'll fail, and that's fine. It doesn't have to, we don't have to agree. Caitlin Mule in Canada has done some great Delphi work trying to get people to agree wording, and the wording is agreed, the thing is probably not. And I think that's really important. Because we won't all agree it's the same thing, I don't think we can all agree that it has the same impact, that it will have the same outcomes. It's more useful for us to say, how has this social prescribing been implemented for who, and what does success look like? And we have to be very clear about that at the outset. Because social prescribing had those blurred boundaries, and because people couldn't agree that it was all a consistent thing, it immediately became a pressure release valve for a system that is under huge strain and is struggling to keep up. And it will continue to be so because there is that blur around who's eligible, what pathways look like, and who delivers them. It will continue to be that pressure release valve. And that is damaging in lots of ways, but also on link workers. We need to really look after those link workers. That also means that social prescribing might be seen to be responsible for saving things it can't. So that first red line from NHS England was reduce pressure on the NHS. It may do in some ways, but it may not in others. Social prescribing shouldn't be held responsible for removing pressure from the NHS in terms of primary care visits necessarily, because that isn't really within its gift, I suppose. We can't hold it responsible for those things. Linked to that, the needs in the community are greater and more acute than anybody in policy first thought, and they're getting more so. So things like social prescribing are ever more needed, but they are doing different things than was intended. And then my last point in terms of looking ahead is that those link workers in all our interactions with them have genuinely been amazing. They are fantastic people doing the right thing, but they need support, training, skills, clinical supervision, resource and time. And they have been a joy to interact with, I would say, universally. What have we done? I'm aware we're running out of time. I've talked about a few of the projects that we've been involved in, and there's another few here if people want to go look them up. So we've done some realist review work looking at the pathway, trying to unpick that. We've been really interested in the Southwest in the researcher in residence model, putting researchers in places where practice is happening and vice versa, so that we can try to close that implementation and evaluation loop a little bit. I've been quite interested in social prescribing that happens outside of the health service. So we've done some complex systems mapping of what that looks like. I've done quite a lot of policy work with National Academy and DEFRA and others. And then with Stephanie Tierney, as I mentioned, we've done quite a lot of work around the link worker role and how that's rolled out. Young people have been very interested in that. And then obviously some COVID work, everyone did COVID work. Social prescribing had a role to play there. What we're currently doing is, again, I've said and think presented some of those, the SPEU trial. I think that's really making some interesting evidence around Europe about what social prescribing might do. We're also doing some work around how social prescribing might work for severe mental illness, and I think that's really interesting around children and young people, of course, and then around the voluntary sector and how the impact of social prescribing is sort of being felt around the voluntary sector, especially around roles and people doing that work, and then some more green social prescribing. And we're starting to get really interested in that Chewy role. So if anyone's got any experience, I'd love to talk to you. We're starting to think, how can that role sit alongside social prescribing link workers? What's that rollout going to look like? Are we going to make the same mistakes that we did with social prescribing? So that's me. Feel free to drop me a line. And then my last slide is the one that Holly wanted me to show on the masterclass. So feel free to click those links, do the QR code, all that kind of stuff. That's me. I'll hand back to Angela.
Yes. Hello. So, Karen, thank you so much for a really fascinating talk. It's given us lots of things to read. And also thank you, everybody, for bearing with the slightly chaotic start, but we got there in the end. I'm keeping my eye on time, obviously, because we're due to finish at 11. We've got time for a few questions. I've noted some in the chat, so I'm just going to pull a couple of those out, if that's all right. So one of the first ones is there a standardized questionnaire to measure I've missed it. The outcomes or effectiveness of social prescribing interventions pre and post.
Yeah, a brilliant question, and in fact, the $64 million question. So there's a bit of a story there, as there always is. Um, so no, basically, is the answer, but the intention was there. So when NHS England rolled out the link worker role, they had those three things that they were really interested in, and those three domains became, excuse me, became the domains that they were interested in for outcomes. So impact on the individual, impact on the system, and impact on communities. And then they suggested a load of outcomes that talk to those domains. So for example, for an individual, there was the suggestion that ONS4 was a good way to measure well-being, and then various others. So there is the NHS outcomes framework, and I guess in theory that does the thing that the questioner says, but actually it isn't universally accepted and lots of people wouldn't use it. So link workers tell us, for example, that ONS4 doesn't fit the conversations that they have. They don't find that it's positively framed enough, so they tend to not really like that outcome universally. And then there's so many different ways of running programs for different cohorts in different ways that I think what's probably more standardized is the mapping around what that pathway looks like. So again, my diagram, capturing information around the cohort, the referral touch points, who it is, where they do it, how long they talk for, the link worker touch points, again, where they meet, how long they talk for, and the activities, number of sessions, adherence, fidelity, and all that kind of stuff. That implementation mapping is a bit more standardized, but outcome metrics much less so. And there's probably a good argument that we shouldn't, to a great degree, set those as standardized. My one caveat to that is there's some really interesting work coming out of NASP and NAPC from Jag Mundra, which is a very simple question related to symptom and healthcare management. How do you feel about managing your symptoms today? And something like that feels like a really good idea for social prescribing. Is it doing the thing that addresses the thing that you're concerned about? So it's a really long-winded no.
That wasn't a long-winded no. That was a very erudite long-winded no. I have a question about the rationality and the theory of learning, which informs the social prescribing model. If I understood you correctly, you said there isn't necessarily just one model, and I wonder how that relates to the question.
Yeah, so I'm not sure there's a universal, well, there isn't a universal model of social prescribing. People do it in different ways in different spaces. Each of those boxes that I presented has a lot of blur around it. So even the link worker, for example, they could be in primary care, they could sit in a GP surgery, they may have access to all the patient records. But we've also seen really good examples of where great link working is done by the person that works in the laundrette in their local community. And somebody has said, oh, go and chat to so-and-so. They know everything that happens here. And I'll go and have a half an hour conversation and they'll go and do something else. So that really impacts, firstly, on there isn't that one model of social prescribing, and actually it can be done in various different ways. We're just capturing the blur around the edges. And secondly, a lot of it has sort of been rolled out in a way that's largely theory-free. So Sina Evers at the University of Bremen did some great work looking at the theories that people talk about when they write up social prescribing. And there are the normal theories that you would expect in terms of health promotion, so health determination theory, all that kind of stuff. But in terms of the actual program, they're largely done theory-free. And that means that that implementation is done in various different ways. And I think for me anyway, it goes back to that outcomes question. If we capture what is being delivered to whom, by whom, at what points and in what ways, then the outcomes flow from that, and that becomes a little bit more sensible.
Perfect, thank you. I'm still cherry picking through my massive questions. I have a question about whether or not you think social prescribing has transformed the culture of GP practice. Nice, easy one.
Yeah, that's a great question. No, So transformed is probably the key word for me there. So um, there's a really good argument that good general practice was doing this stuff really quite well anyway. Family doctoring is always integrated with community health and that kind of stuff anyway. Um, in terms of the systematized social prescribing, the investment that happened in 2019 and since, um, well, I mean, GPs aren't a coherent bunch necessarily, so there'll be champions for this in primary care, and there are some quite high profile ones. There are people in the middle who don't really care one way or the other, and there are some quite vocal detractors. I would say for the most part, I have seen this becoming another tool in the general practice toolbox that can be deployed in some ways, and so not transformed, but potentially aiding in particular ways in particular places. I've also heard a little bit of pushback around social prescribing not doing the thing that was pitched to primary care, which was that it would remove pressure and visits to primary care. And it hasn't necessarily done that in the way that was pitched. So transformed, no. Helped in lots of ways, probably yes. But not in the same way for everybody.
Okay, perfect. Thank you. I think we probably have time for one more. It's sort of a comment and a question. This idea that is there a universal language, or are there different sets of languages that you can use for different audiences? So, for example, we talk about social prescribing. How would you describe that to a member of the public, for example?
Yeah, really. Yeah, great question again. So we've just been wrangling with this in our social prescribing EU trial, where of course we've got multiple languages, different places, different spaces. And it's really hard. And what we've tried to do is to just be really transparent and open that social prescribing as a term people don't really like. And I'll come back to that. But we just try to describe who the people are and what they're going to be doing. So you've come to primary care. There is this person in the office down the hall, and they will talk to you for 45 minutes. They will have some sense of what's going on that you want to solve and what is around in the local area, and they will help you design a plan. And that plan will probably involve X, Y, and Z. And that's for us a really open and transparent way of describing it. People don't like the phrase social prescribing for two reasons. They don't like the phrase social, and they don't like the phrase prescribing. And people say that it's too medicalized. It's got lots of power dynamics wrapped up in it. Uh, and I kind of think that's okay, because that describes social prescribing. It's not universally loved. People do disagree with it for those reasons. And it often is quite medically driven. It often does sit within the health service, and it often does exacerbate existing power inequalities. So people don't like the term, but they probably then don't like the thing. And that's probably fair enough. I don't disagree with any of that. So there's quite a long history, and there's lots of politics wrapped up in there. And I'm not trying to be political. It's just, yeah, that's often the pushback. We don't like social or prescribing.
Perfect. Thank you. I think that's probably us almost out of time. Just leaves me to say a huge thank you to Karen, and particularly for stepping up so bravely in the midst of couldn't speak, couldn't put the camera on. I hope everybody found the session enjoyable and informative. I definitely did. And the recording will be made available on the IHP website in due course.
Thanks for having me.
You're welcome. Thank you ever so much, everybody, and well done for getting over to the right room. And I shall close the meeting now. Thank you so much.
Thanks a lot.
Bye.